Good evening, everyone. I'm Dr. Pragnya Chigurupati from AIG Breast Center in Hyderabad. I'm sorry I couldn't be there today, but today's abstract of discussion is how do intrinsic biological factors impact the risk of lymphedema? And this was a multifactorial prognostic modeling study of patient-specific lymphedema risk factors, which was studied at the University of Toronto in Canada. At the offset, I'd also like to thank the organizers for having me on this talk. This is my team at AIG Breast Health and Gynecology Center. So without much ado, to begin with, let's talk about breast cancer-related lymphedema, which is a much feared sequelae of breast cancer treatment resulting from the disruption of lymphatics that prevents adequate drainage from lymphatic vessels, causing protein-rich lymph fluid to accumulate in the interstitial space. And this is something we all know. This excess fluid can cause abnormal swelling in the breast and trunk or the upper extremity on the side of treatment. Depending on the extent, the symptoms of lymphedema can include arm tightness, heaviness or fullness, pain, and impaired lymph function. But let's not forget that even cosmetically, it's quite bad. Furthermore, as lymphedema progresses, adipose deposition and fibrosis can result. Breast cancer-related lymphedema negatively affects a patient's quality of life, causing elevated rates of depression and anxiety, in addition to physical impairment compared to patients without lymphedema. Let's not forget that we should include the cost factor, which is hugely impactful in a patient's life. The overall estimated incidence of chronic arm edema after breast cancer was found to be 21.4%, indicating that this problem is a widespread problem affecting at least 1 in every 5 patients following breast cancer treatment. However, due to lack of diagnostic criteria for breast cancer-related lymphedema, the reported incidence varies from less than 5% to more than 50%. Multiple different kinds of cancers do cause lymphedema, but the highest amount and the most number of cases is unfortunately related to breast cancer. The likelihood of any individual developing lymphedema depends largely on the patient's individual risk factors. It could be treatment-related or non-treatment related. Axillary surgery and radiotherapy obviously do cause lymphedema, and this is well known. However, we do not have enough data on neoadjuvant or adjuvant chemotherapy. Some papers say that it could alter the lymphatics, causing lymphedema. Breast reconstruction. Certain patients, especially those with whole breast reconstruction, and even those with local flaps, etc., do cause an elevated risk of lymphedema. And non-treatment related. Higher the age, the more chance of lymphedema. BMI. The higher BMI, the more chance of lymphedema. We also have data on subclinical edema and cases of cellulitis of the arm causing lymphedema. But however, we do not have enough data to prove that these are the factors that definitely cause lymphedema. As cancer and treatment-related risk factors do not fully account for a patient's risk, this prognostic study investigated the role of patient biological factors in determining the lymphedema risk. According to the International Society of Lymphology, there are 3 stages. The first 2 stages are those which can be reversible, whereas the second and the third stage are those where there's fibrosis and excessive accumulation of adipose tissue, which is predominantly irreversible. These patients, if they're treated at an early stage with either physiotherapy or any particular intervention, lymphedema can be reversible. That is the early stages. However, if it's not caught until the late stage or they do not take any sort of treatment for it, the consequences of lymphedema include psychosocial stress, increased risk of cellulitis, less than 1% chance to develop a highly lethal cancer, which is lymphangiosarcoma, and of course, more than 30% higher medical costs. So this study hypothesized around the fact that certain patient-related factors such as vascular, inflammatory, or adipose deposition or fibrotic predisposition or other cancer-related and treatment-related factors increase the risk of lymphedema occurrence. This was a single institutional retrospective study, and all study participants received clinical cancer care at Princess Margaret Center during 2016 to 2018. A total of 676 records were taken out, and after the patients were excluded, certain patients were excluded, the total number of patients who were eligible and included in the analysis were 373. They were grouped into training and validation cohorts by random sampling. 7 patient-related risk factors, 7 cancer factors, and 6 treatment factors were evaluated by univariate and multivariate linear regression analysis. Model performance was evaluated with correlation testing and comparison of receiver operating characteristic curves. Both the groups were comparable in terms of all the characteristics, and the mean age being 52. Mostly the patients were early breast cancer, and a mean follow-up was 2 years. The treatment factors which were included were mastectomy, axillary lymph node dissection, chemotherapy, breast chest radiotherapy, and regional nodal irradiation. Patient-related factors were age, BMI, history of any vascular immune disorder or surgical seromas, pre-treatment hemoglobin, and mammogram breast density. This is one of the only studies which included mammogram breast density as a predisposition factor to lymphedema. They hypothesized around the factor that more the fatty, the more chances of metabolic syndrome and increased adipose deposition. The other cancer factors that were taken into consideration were diagnosis, that is the type of cancer, receptor status, stage, tumor size, and pathological nodes. So the results were that a total of 373 patients were included. On univariate linear regression, there's age, BMI, history of vascular disease, and mammographic breast density, which were the significant patient-related factors. Axillary lymph node dissection, number of nodes dissected, and regional radiation were the treatment-related factors which were found to be significant. And cancer-related factors which were significant were higher stage, greater number of involved nodes. On multivariate linear regression, 3 patient-related factors, which were age, BMI, and mammographic breast density, which were found to be significant. The pathological lymph node burden, which was a cancer-related factor, and the use of axillary lymph node dissection, which is a treatment-related factor, were found to be significant. The mammogram, and based on these factors of multivariate linear regression, they used a formula which was used to calculate the lymphedema volume. And amongst all the factors, mammographic breast density provided extra information beyond BMI as a factor of fat deposition. The resulting 5-factor model could predict the occurrence of lymphedema with AUC values of 0.86 and 0.83 in the training and validation cohorts, respectively. And the value which was found to be of significant value was supposed to be 1. And this shows a good reproducible performance. Lymphedema-free survival was found to be 58 at the end of 2 years in the high-risk group and 91% in the low-risk group. And this was similar in both the training as well as the validation cohorts, which shows that this model shows a reproducible discrimination in both the groups. The study concluded that certain factors, such as the 5 clinical parameters, the 3 intrinsic patient factors, which were mentioned earlier, could be used to predict the occurrence of severe upper extremity lymphedema in breast cancer patients after cancer treatment. So in my opinion, studies like this could actually help us identify patients, which would help us identify initiating early physiotherapy and other exercises to prevent this condition in patients. Also, they would help in adequate counseling of such patients prior to the procedure. So, for example, certain patients had a few factors which could predispose them to an increased risk of lymphedema. We could counsel them initially and also plan certain intraoperative procedures, such as probably an axillary reverse mapping or lymphovenous anastomosis based on their risk. Or post-operatively, we could make sure that these patients initiate early physiotherapy or other interventions which could prevent lymphedema in these patients. The limitations of this study is that it's a retrospective study. Breast edema was not studied, and it is a very short follow-up, because sometimes most of these patients, they develop lymphedema in the first 2 years and they gradually settle. So well-conducted randomized control trials or more meta-analysis might be required to get more information about the factors that may predispose to lymphedema. Thank you.